Good day, my name is Jessica. My mother's side of the family are settlers to Turtle Island, originally from Germany, Ireland, and Sweden. My father's side of the family are settlers from Finland and Austria, and indigenous Tsimshian from Southeast Alaska. Just thank you so much for the opportunity to be in community with you all today. Dr. Skinner and Noreen for all the work that you are doing, and Jody and Jolie for the work and the stories that you shared and the power in those stories. I've worked in tribal healthcare for 17 years and currently at the Northwest Portland Area Indian Health Board. The board serves the 43 tribes of Washington, Oregon, and Idaho, though much of my work is national in scope. And spans Indian country, especially as it relates to hepatitis, HIV, and infectious disease. And when I'm saying Indian country, it's a very positivist, reclaiming term that many indigenous people use in the United States. And I do also want to note that there are 474 different tribes, and it's not a monolith of indigenous culture. Every single tribe has their own government, their own culture, their own history, and their own experience with colonization. So with that said, I'll just take a few minutes to briefly go over the hepatitis C journey from a national perspective, working with federal, tribal, and urban facilities in the United States. Next slide, please. I see a lot of similarities with our Canadian colleagues, a lot of them. And I just put some images up here that kind of speaks to some of the work that we've done. But one item that struck me from their paper was that their access to DAAs started in 2016. That's a full 4 years after the DAA introduction. And everyone here is going to be familiar with the paradox faced for health systems in the early years. These drugs were life-saving and even in their record-setting prices, arguably cost-effective at an individual level. The high SVR rates with few side effects changed everything about how we could address hepatitis C, but the drugs were not affordable at any kind of reasonable scale, and treatment remained rationed and very rare in Indian country. And while the barriers to drug access are much lower than they were before in the beginning, barriers still exist in many states and within many Indian Health Service tribal and urban facilities. Next slide, please. And ID-related challenges, hepatitis C-related challenges are not happening in isolation and are not very different from other health issues in the Indian health system. It's really well documented that determinants of health are at the core of the issue. Many communities have both a disparity in poor health outcomes compared to the national average, as well as a disparity in the lack of healthcare resources to address them. In investing in interventions that address non-medical health-related social needs, it was noted that while healthcare accounts for some 10 to 20% of the determinants of health, socioeconomic factors and factors related to the physical environment are estimated to account for up to 50% of the determinants of health. So we just must address these factors if we want to elevate the health of all. Next slide, please. Even with the increasing DAA access, the Indian health system then has another difficulty meeting the needs of the population that it exists to serve based on treaty. 1 in 4 physician positions are vacant in the health system and turnover is high. The average healthcare facility is 40 years old compared with the 10-year average for the US as a whole. And finally, per capita user health expenditure is less than half of the US average. Of course, in an under-resourced system like this, it's going to struggle to have good health outcomes. And while my colleague, Dr. McMahon, will share some of the amazing successes from Alaska, many tribal nations are still struggling today to meet the needs of hepatitis C treatment. Next slide, please. And budget disparities and outdated medical facilities are not bad luck, or they're not a bad card. They are policy choices. As an example, another federal agency that provides direct health care to patients is the Veterans Administration. It's a constituency that arguably has a much higher profile than tribal nations in the eyes of the general US population. The VA serves 4 times as many patients as the Indian health system, but has 31 times as many physicians. The VA has received several $billions for hepatitis C treatment. The Indian health system has received $0 for hepatitis C treatment. Other key services that are, of course, part of hepatitis C elimination are also not funded. The VA has an opioid use disorder and mental health and substance use disorder budget 66 and 27 times greater than the Indian health system. My purpose absolutely is not to disparage the VA, go VA, but rather to show that this under-resourcing is a deliberate policy choice, and it's a deliberate policy choice that can be changed. And I understand that budget is not alone sufficient to eliminate hepatitis C, but it's absolutely a necessary one. And resources have translated into outcomes here. The VA has nearly eliminated hepatitis C from their population, and the Indian health system has no target date to do so. Next slide. So I know that was all a lot of, seemingly negative, but it's the facts and the truth, and it's something that we absolutely have to move through in order to change. But there have been tons of successes in Indian country as well. Like the example from Saskatchewan, successful programs in our system have consisted of local prioritization and customization of hepatitis C programs for outreach, for testing, for treatment, and elimination programs are underway in several of our tribal networks. One main pillar of our ITU response so far has been screening using a national recommendation as rationale. Best practices like clinical decision tools and EHR prompts have resulted in our national hepatitis C screening average going from 11% in 2012 to 60% in 2020. And then, of course, all of this screening has led to the inevitable question, what do we do for our patients who test positive in a system that's far from specialists, like Saskatchewan, that's understaffed, probably like Saskatchewan, and unable to afford the medications? Next slide. Our solution and our strength in treatment has really been from our clinical community, brought together by our Indian country ECHO clinics. From starting with one single clinic a month, we've expanded to several clinics each month nationwide, and we create communities of practice to improve hepatitis C treatment access and quality care for our people. And in doing so, patients are treated right in their community by clinicians who they know and who they trust. Collectively, the Indian country tele-echo consultations have helped treatment for over 1,000 different patients directly and thousands of more indirectly. And in fact, tele-echo support is a key factor in the existence of most of the hepatitis C programs that are out there in Indian country. In an evaluation, we found that about 44% of the facilities were using Indian country ECHO services. The ones who were using those services accounted for 92% of the DAA prescriptions in the network. Next slide. And just on a personal level, working on the problems presented by hepatitis C mortality, which is double in our population, has been a journey from local screening programs to demanding resources for the Indian health system. Hepatitis C mortality in the US, including tribal nations, is finally trending down, and I'm grateful to have been part of this national effort and continue to be part of it. But I'm also really frustrated to know that what might be. And I'm more aware of ever that the impact of policy choices, both historical and present day, what they're having on our tribal nations. And I won't stop and I won't be quiet until treatment for hepatitis C is available to all of my people.